Okay, so our next talk is entitled Supporting the Small Practice, Advice for the Consulting Physicist, to be given by Bob Pizzutiello.
Thanks, Diana. So I have to really make sure that I stay on time, because if there's anything that a big man fears, it's a strong, small woman. I know, because I'm married to one. So I'm delighted to be asked, and sort of not sure I'm exactly in this league of the rest of the speakers, but I'm going to do my best to try to tell you the kinds of things that we have been learning and continue to learn, and hopefully it'll be useful to people in the organization, in the room here. So my objective is a few things: to come up to speed on how do we come up to speed on a wide variety of scanner types. This is really easy because Cynthia just did almost all that. How can we leverage our experience from one site to another? How do we build relationships that encourage our clients to seek our input on protocols? And the last one is maybe the trickiest, which is saved till the end. How do we address protocol problems once we find them, particularly if the site is not willing to pay for support? Okay. So here's the outline. I'm going to start by asking, what is a consultant? Talk about the scope of this project as we have come to understand it, and it took a while for us to get there. Talk about the benefits and challenges for the consultant, and they're sort of in three types. There's technical challenges and benefits, operational, and professional. And then I have a few recommendations or advice at the end. So who is a consultant? Consider this case. A 33-year-old pregnant female, 18 weeks, presents to the emergency room with severe headaches and labored breathing. So the ER physician orders CT scans of the head and the chest to rule out pulmonary embolus. So the ER physician is the primary. They get an OBGYN consult. They get a neurologist consult. They get a radiology consult. And ultimately, they're going to ask for a medical physics consult. So if you look in the dictionary, which is now, of course, online, I still have my old one from when I graduated high school. The dictionary defines a consultant as, at the bottom, one who gives professional advice or services, someone who's an expert. So my question is, who is a consultant? How many people in this room would identify themselves as either primarily or secondarily a consultant? Okay. Now, how many people think that under this definition, the broader definition, that they're also consultants? So I think really, if we're not primary care providers, in some way we are consultants. So according to that traditional use of the term, we are consultants. According to the dictionary, we're all consultants. Really, medical physicists don't generally deliver primary care. Now, there are issues for full-time hospital staff physicists that may be somewhat different. However, there's a lot that we have in common, and I'm hoping that there's going to be something in this talk for everybody. So let's start with the technical benefits and challenges. The biggest one of the biggest ones, is the diversity of manufacturers and models. And how are we going to approach this? Well, what we decided to do was, how did we start dealing this when we started helping facilities get ACR accredited in CT back many, many years ago? Well, we started with one or two sites, one or two manufacturers, and tried to get a handle a little at a time. We knew we needed to allow extra time to refine the process. The same thing applies here. In the beginning, when you start this CT protocol review, it's not going to be quick. We have to consider whether or not you want to charge for things at first that you're not good at. One of the things is I believe that we're experts, but if I'm learning, I don't want to be charging while I'm learning. That just reflects poorly on everybody. So your early negotiation maybe with the first couple of facilities is, I'll work with you on this, we'll learn together, and we either won't charge or we'll have a very reduced charge. And then, later on, you can develop an expertise that you can market. Choose a receptive site, management, personnel, and the schedule, because you're going to need some time on the CT scanner to play with the protocols. Form and lead a CT protocol review committee. That's really the essential message. Build your own scanner-specific protocol table, understanding the terminology for each scanner manufacturer, and again, Cynthia's poster will be hugely helpful in that regard. And then pilot the project, start at a couple of places, and identify some success milestones. Say we succeeded with brain perfusion, and then move on from there. So the scope of the project is to start by obtaining grassroots support. Present the case to the decision makers, lock down all your protocols, subject to approval by someone at a higher level so that staff technologists don't either directly or inadvertently change the defaults. And even still, as we're getting around to facilities since we started figuring this out the end of last year, we're finding places that have not got all their protocols locked down. That's a first most important step. Form that CT protocol review committee. It needs to consist of a radiologist, a CT technologist, and a medical physicist. Start with the easy ones, perfusion and pediatrics. Perfusion has had a lot of press. Everybody's most interested in pediatrics. I'll tell you that some of my facilities don't do pediatrics, and lots of them don't do brain perfusions. Review the clinical considerations, the dose, the protocol details, and try to establish a dialogue about how you can try to optimize these image protocols. Generate some recommendations, some trial solutions, and then, according to my very dear friend Doug Pfeiffer, he's been doing this successfully at his hospital, meet monthly. Now, monthly is a tough call, but it's certainly an ideal way to do it in the beginning when you have a lot of protocols to get through, and if you're able to meet monthly in the beginning, you can kind of get some momentum going. And then reevaluate, and then evaluate some more protocols, document the process and the results. So now you have to motivate and sell people on this product. So one of the things that you can show is, if we do the work, you could come up with some really very fine protocol sheets to use for your technologists, and these are just two examples. Well, how about the diversity of manufacturers and models? It's an opportunity and a challenge. Start with the data that we're going to be putting up on the APM website from this summit. Use other web resources, which I'll show you a few, but start your own database and grow it so that when you go to another place, you don't have to necessarily tell people what to do. But what you can say is, at another facility with the same scanner, this is what they found worked. Would that work for you, or would you like us to modify it for your needs? Then you're sort of not coming out and telling somebody what to do. You're just reporting that at another place, this is what worked. And then they'll say, well, we don't like that. Well, fine, let's change it. You're sort of not putting yourself behind any specific protocol, but you're helping to engage in the process and discussion. And network with other colleagues. You know, one of the nicest things about being a diagnostic medical physicist, it's a small community. You know, there's 200 people in this room, and I bet 150 of us know each other by first name basis. So then create a list of rules of thumb. And we got these from Frank Rinaldo, who came out and spent a day with us and helped us learn more about CT. So these are just some samples. So, for example, you should have some rules of thumb about KVP. And they might be something like 120 kV for adults, 100 for small, 80 to 100 for peds, 140 for very large adults. When would you change the KVP? Well, you'd change the KVP to maintain the noise, and there's some more details here. But I got to tell you, you have to update these frequently. I know that I will after this summit because I've got 7 pages of notes from the morning. More rules of thumb. What about slice thickness? Thinner slices, of course, give us better axial resolution with less partial volume effect, but they require more MAS for equivalent noise. So try to make sure that the radiologists understand that when you're having the discussion, and then the slice recon incrementation, and the scan time, and all the things we've been talking about all day today. What about the pitch? Talk about the pitch in terms of the speed of the exam and the artifacts, mostly important for breath holds, but also for peristalsis. So think about and talk with your radiologists about what the clinical endpoint is, what are you really looking for, and then it's our job to work with the technologist and say, this is what your machine can do, this is a protocol that might be best. Of course, in the automatic modes, adjust your noise index or reference MAS so that you can try to get an optimal dose. So then, what can I add to this when I get home? I know I have more homework to do when I get home, not just the homework we're going to get at the end of the night. How did we prepare in our practice? Well, one of our clients asked us at the end of last year to help with a protocol review, and we really didn't know what to do. So we went out and took a look, and it was very complicated. A lot of different protocols, a lot of reasons why each protocol was unique. So we knew we had to go back to school and learn a little more. So what we did was we started by studying each manufacturer's features, terms, and quirks. And we engaged an experienced CT physicist. We asked Frank Rinaldo to come out and spend a day as a visiting professor with us in our residence. The whole day we spent talking about CT and protocols. And we learned a lot. But then we knew we had to understand better what the clinical needs were. Well, we didn't have the benefit of this session, so we hired a radiologist to come in and spend a day with us and talk about each of the modalities and what he was interested in terms of CT imaging, motion, reconstruction, all these things that were important for him. Also, use the AAPM resources, and there are many more to come. And there are a bunch of web-based resources. So I did a little looking around. I think most of us are familiar with the Image Gently resources. Now, of course, there's the protocol reduction table that you can download. This is what that looks like. The MAS reduction factors for peds based on your abdomen baseline. And this is a good starting point. Many places find they're even able to do lower doses. The manufacturers have information available on their websites as well. And many of the manufacturers, you can download information on their scanner individually. There's this website called CT is Us. It's from a radiologist in Pennsylvania. And actually, I started to check around, and it's a pretty reputable site. When I looked 2 years ago, all the protocols were really old. But when I looked 3 weeks ago, a lot of the protocols have been updated within the last 4 months. So I think this is another good resource to look at. They have data for both the Siemens and the GE systems. Okay, so that was a technical challenge. Now let's talk about the operational challenges. It's a big project. Trying to talk about CT protocol review is really big. It requires, first of all, significant institutional will, resources, and cooperation. It could potentially be the largest patient benefit of anything that we do in medical physics. If you think about all the importance of clinical information that comes from CT scanning, and the fact that CT is pretty much the highest dose procedure that's done for a lot of patients, our impact can be huge. So from an image quality first, second from a dose, and third maybe from trying to get a dose as low as we can for the image quality we need. It's not exactly a LARA, but it's something like that. This is a place for us to make a difference. The process and the results will be useful, first of all, for professional development, not only for ourselves, but for the radiologists, and for marketing in a competitive environment. One of my clients said, what can we do to market ourselves? Can we say that we have the lowest doses in CT? I said, no, that's not what you want to say, right? We know that. Of course, that's what the marketing types want to be able to say. But maybe we could say, we've created a committee that does ongoing continuous review of optimizing CT protocols and image quality. That's something that's useful to the marketing types, which helps to justify the time and the cost to do the project. Similarly, for us as medical physicists, as we develop expertise in making this happen, it can be useful for us in marketing our services as well. So here's a little math, not a lot. But I took a look at a few hospitals. These are small ones in my example. So the one on the left is a very small hospital with a 16-slice scanner. They have about 44 protocols. They probably use about 20 most of the time. But as we get to bigger hospitals, the number of protocols increases, and I left off the ones that are 200 and 300 protocols because we have some of those facilities too. So the number of protocols can be big. You have to decide where to start and then just nibble away at the ones that are the most important. So what are the obstacles? And these are all things we've heard. There's no money in the operating budget for the department to do this. So sometimes you have to think bigger than the department. The CT schedule is full all the time. We can't give you any time on the scanner until 10 o'clock, but we're not willing to pay the staff overtime to sit with you and work through the protocols. We'll alienate the referring doctors because we have special protocols for a whole bunch of doctors who want it their way. Well, how can we deal with that? There are some ways to deal with that. No radiologist is willing to spend the time. This is particularly tough in a private practice model where the radiologists are used to coming in and going home at 5 o'clock. But if you can make the case of value to the practice, then maybe you can get that radiology practice to give that radiologist some administrative time to work with you on the dose protocol committee. All radiologists will never agree to standardization. A really dear friend of mine who's a radiologist said, you can't get 3 radiologists to agree to leave a burning building. Technologists are too busy. All protocols are fine because the manufacturer set them that way. We know better, even from our very limited experience with the ACR-CT accreditation in the head abdomen and pediatric abdomen, that a lot of those protocols were not optimal, and we helped to make them a little better. There's no regulatory requirement. Not yet. So the benefits to the medical physicist, then, there are professional benefits. And really, this is the reason why I do this. I love it because I'm kind of hooked on making a difference. I think we can make a real difference if we put in the effort to learn how to do this and work with our facilities and make it happen. It's incredible professional development for us, expand our knowledge, and it also helps us with the ABR MOCs. I'll talk about that in a minute. It allows us to become essential. And I think diagnostic medical physicists started on a bad road 20 years ago when physicists used to come in the middle of the night or on weekends and do their testing while they had. Physicists don't do testing. We need to do more than that, and we need to become essential. This is a way to become essential. It lets us build our relationships with radiologists and technologists, gives us increased visibility, and ultimately helps us create and refine a new medical physics service product. It lets us do something else that is of value and in the long run will generate revenue for our practices. Well, what are the costs to the medical physicists? It's very time consuming. On-site meetings, ongoing project documentation. And this is a big one. The cost, the reimbursement that we can expect to charge for this service may not be consistent with the really high margin things that we're able to do elsewhere in our practice. But you know, this is life. If you want to do the right thing, some things you generate more revenue for and some things you don't. If that weren't the case, no place in this country would do mammography. We have to do the right thing. And in the balance, we also have to make sure that there's enough revenue for our practices to continue. Do we have the staff? This idea came to me 2 nights ago. It's hard to do this because it's time consuming. Well, some of you know that we've started a residency program in our group. We just are bringing on our 3rd resident, one each year for 3 years. So if you think you don't have the staff, maybe you should think about whether you could create a residency or hook up with somebody who has a residency. We desperately need residents in diagnostic medical physics. So if you had a resident, maybe in the beginning, they could do some of the routine work that you have medical physicists do that really don't require an experienced physicist. So you free up the experienced person to do the CT protocol review. It can give you maybe another half FTE equivalent without having to spend the money for a half FTE physicist, and they're awfully hard to find. So about building relationships, you need to sell the concept of CT protocol review. It's not easy. But I present that it's a natural progression. We do entrance skin exposure analyses. We do entrance skin exposure rate analyses for fluoro. Why would we not do CT, since we all know that CT accounts for a tremendous number of exams and a tremendous amount of the dose that's delivered? So you can make that case. The RSO is responsible for doses in general, and some RSOs at facilities are very sensitive to that. So that might be a way to sell it. State regulations may very soon specify CT dose review. In order to make this happen, the medical physicist has to commit to and really be available for consultation, knowledgeable both technically and clinically, or at least willing to learn. By coming here, obviously this is the choir, right? I'm preaching to the choir. Willing to participate as a team member. We learned this in mammography very much, and I'll come back to that in 1 minute. Willing to invest the ongoing effort to make it work, and to step beyond our testing comfort zone. I think those of us who are hands-on medical physicists have a comfort zone. I can get into a room, I can go through a series of performance evaluations that I've done for years and years on hundreds of systems, and I'm very comfortable. The question is, can we step out of our comfort zone, talk with our clinical colleagues and the technologists, and say, can we take all this knowledge that we have and help them to really change clinical protocols? Think about mammography. 15 years ago, after I'd done a couple of hundred mammography surveys, it dawned on me that the technique charts were not good. So I remember calling up Ed Hendrick once, and I said, Ed, some of these things are really bad. Do you think we can tell them to use a different technique? Because some people think they have to do all screen film imaging at 25 kV, and their exposure times are 4 seconds long. Doesn't make sense. He said, Bob, who knows better than us how the image is formed and how the equipment works and how the image is supposed to look? Of course we should talk about techniques. So I say that this is a logical progression from mammography to CT. It's our responsibility to talk about CT protocols. So what are the motivations for the radiologist? Well, there's patient care, but it's very useful when answering patients' questions to say, we've reviewed all of our protocols and we have an ongoing system to review them. There's the ABR Maintenance of Certification program. And then if you want to market to other physicians, again, the radiologist can say, we're doing this CT protocol review. So what does the ABR have to say about maintenance of certification? Well, it applies to everybody, not just medical physicists. Radiologists have to do it. And there are these PQI, these practice quality improvement guidelines. And there's some material here which you'll get on the handout, but it's on the ABR website. Well, if you go to the Image Gently website, They will show you PQIs that they've already had approved for chest CT radiation safety and for pediatrics. So this is an example for why a radiologist should spend some time, because they can then do their own PQI. We can get our MOCs, and I'm running out of alphabet letters, but we can get all the things then we need to for the ABR. There's another organization called RQ, which is a bunch of radiologists who help to create a library of PQI projects. So there might be a way to interface with them. Another motivation, obviously, nobody wants to be front page headlines. Bad things can happen. But we have to think about accountability in medical physics. We can build on our past successes. We've talked about entrance skin exposures, CR indexes, the ACR work that we've done with only 3 protocols, and image gently, but we can do more. We need to start with the CT technologist and the radiologist and remind others of those congressional hearings. The FDA has a position statement, which I'm sure we're going to hear more about, which is a white paper on initiative to reduce unnecessary radiation exposure from medical imaging. And the key point here is in yellow in the first bullet, careful optimization of the radiation dose used during each procedure. That's pertinent to us. The justification is most pertinent to the radiologists. If we don't act on this, I wouldn't be at all surprised to see states and other accrediting bodies and regulations starting to force us. So why not get on the front end of it? So a couple of points of salesmanship. Why should they do it? It's patient care. Patients and board members are already asking the question, what is the dose from our CT scanners? Would it be helpful to say, we have an ongoing program to evaluate our doses? And there are potentially emerging regulations, accreditation requirements, or interpretations of these things that are going to force us to do protocol review. So who are the decision makers? Well, they're listed here. On the next slide, I tried to think about what do these decision makers have control over? Well, the CT technologist supervisor is mostly interested in patient care and standardization. They can probably authorize the time on the scanner. They don't probably have responsibility for finances to pay for us to do this work. And they have maybe some responsibility for staff, but they're not going to have any control over the radiologists. So if you look through the radiology and manager, you see that people have different concerns and different degrees of authority. At many facilities, the radiation safety officer and the RSO is a place to go to get authorization because their motivation is to avoid incidents and to be in compliance. They may be able to motivate the radiologists, and sometimes they can control the dollars. Ultimately, the administration and risk management people in hospitals want to make sure that there are no incidents, no publicity, no legal problems. One of our hospitals told us recently that the board of directors said that they refused to sign their minutes of their meeting until the hospital management came back to them with a plan so that they could be confident that these CT problems and radiation incidents and radiation oncology were not happening in their facility. If you don't know it, board members at not-for-profit hospitals have some personal fiduciary responsibility when things go wrong, and the last thing anybody wants a board member to do is to get dragged into a lawsuit. So sometimes the board level can motivate releasing the funds to do what needs to be done, even if there's no money in the operational budget. These are the key ones that you need to think about: the CT supervisor, the radiology manager, and the radiologist. So 2 final bits of advice. Teaching technologists is a win-win. Teaching them how their scanner works, the meaning of CTDI and DLP displays, and setting some trigger levels. This is from Doug. Teaching them to understand what the dose information really means. It is widely misunderstood. The last 3 things I want to talk about are how to present our recommendations. So this is the style that we use, which I would suggest for you to think about. We try to do like a physics lab report, right? What did we observe? We observed that the default protocol for X was initially set for describe it, but the dose and image quality may not be optimal. These interrelated issues have been discussed with the CT Protocol Review Committee. That's what we observe. Our recommendation is consider modifying the protocol to improve dose or image quality, or both. As documented in the committee minutes, Dr. Rogers, whoever the doctor is on the committee, is responsible to assess clinical acceptability, notify the committee members if there are problems. Caution, changing the default protocols without committee consensus could compromise patient care, both image quality and dose. So that's sort of a standard format to write once you're starting to work on a protocol review committee. Well, what if a facility isn't willing to pay for more support? They say, thank you very much. You came here once. We'll see you next year. What do you do? Well, you can write a little stronger report. You can add a caution that says, changing default protocols without medical physics consultation could compromise patient care. Remember that CTDI displays are not patient dose displays and can be complex to interpret. Without further medical physics consultation regarding protocol changes, we are unable to assess the potential for patient harm due to poor image quality or excessive radiation exposure. We're protecting ourselves, but we're also motivating the facility to say, gee, do I really want that in a report? If something goes bad and plaintiff's attorney sees that, that will be a mess. And finally, what if the site is not willing to start paying for support for protocol review at all? So let's say you're doing your annual medical physics survey for an ACR accredited site. So you can add to your report, at least this is what we're thinking about adding, this report of routine medical physics service is limited to the evaluation of image quality and dose only for those protocols specified in the ACR CT accreditation program, routine head abdomen and pediatric abdomen. We have not been engaged to participate in an overall review of facility protocols. Hence, we are unable to assess the potential for patient harm due to poor image quality or excessive radiation exposure from protocols that we have not been retained to evaluate. Again, we're kind of drawing a line in the sand because a lot of facilities think that when you're in there doing your annual survey, you're going to check the protocols while you're there. Not happening. It's absolutely impossible. So to summarize, we've talked about coming up to speed on a wide variety of scanner types. As consultants, we ultimately will be able to leverage our experience because we have the benefit of experience of many scanners at many different facilities. You got to bite it off in pieces that you can deal with and gradually build your experience and not be blown away by the enormity of the project. Build relationships that encourage your clients to seek your input on protocols. Address protocol problems once you find them, and particularly if the site isn't willing to pay for them, you need to protect yourself and try to motivate the site to do the right thing. So thank you very much. And we have homework to do, so make sure you do your homework before you take your bath tonight. Thank you.
Okay, we have a couple of minutes for questions. If you want to pelt Bob with something while we switch the talks here and get ready for the next one, come on up to the mic.
Just a quick comment. Last summer, the state of Ohio revised their protection rules for CT. There's now a requirement for an annual audit of CT protocols. So it's coming, and it's already here, and it's a real pistol. So be aware of it.
Thanks, Bob.
Thank you, Mark.
Hi, excellent talk, very useful. It occurs to me that we should also be considering in the future here developing an expertise for not only protocol review, but CT utilization review. Most of us have the capability of tracking per patient CT utilization in our radiology information systems. And it's not going to be too far in the future that somebody's going to come and say, well, it's great that we've optimized the abdomen pelvis protocol, but why did this patient have 8 last year? And I know people are starting to think about that, but as physicists and also radiologists, this is an area of expertise it seems to me we ought to be willing to step into. I wondered if you've given any thought to it, or if any of your customers have said, hey, should we be doing this with our ER patients the way we do it?
Yeah, this is a really important question because the biggest excessive radiation is unnecessary repeat exams. We've had some discussions, but part of the problem is that if you're an ER doc on the front line and you say, well, do you really need to do this scan because a patient just had one 3 days ago? We can let you know if they'd had one 3 days ago. They say, I don't care. This patient's in front of me now. I'm responsible for their care, and I have to make sure that this patient is taken care of now. So I'm not sure how much success we would have. Preliminarily, we've been sort of pushed back on that. I would say, though, that one of the things I think is hugely promising is trying to link the order entry system to the appropriateness criteria that we heard about from Jim and others in the morning. That is a direction that I think is hugely beneficial, so that the ER docs, when they order a CT, it's not just we're telling them it's a high dose. We might show them that there might be a better exam to order, and that could be very helpful in the long run, too. Really good points.
Great. Thank you.